Khorana is going to be speaking to us today. Dr. Khorana is a professor of medicine at the Cleveland Clinic, Lerner College of Medicine, Case Western Reserve, and is the chair of oncology research and the vice chair for academic department of the Taussig Cancer Institute. He's been past chair of the American Society of Clinical Oncology, or ASCO, Clinical Practice Guidelines Panel, and really has worked a lot on VTE prophylaxis and VTE therapy in patients with cancer. And importantly, he is now the chair of the Medical and Scientific Advisory Board of the National Blood Clot Alliance. So with that, I'm going to turn it over to Dr. Khorana.
Thank you. Can you hear me okay? All right, so I'll get started.
Yes.
So thank you again for the invitation to discuss. I think my subject here is the use of pharmacologic thromboprophylaxis post-discharge from acute care hospitalization. And so that's what I'll be focusing on in the next 30 minutes or so. Before I start, these are my disclosures, and I'll leave them up for a minute. I think particularly relevant to today's talks are my consulting work with various companies that make either DOACs or low molecular weight heparins. Okay, so I think it's sort of to state the obvious, and I know this has been discussed in other talks today. The VTE obviously is common in people who are in the hospital. And in terms of the public health problem, half of VTE events occur due to hospital admission for surgery or medical illness. So 24% for surgery, 22% related to medical illness. It involves a big chunk of the hospital population. So 40% of hospitalized patients have at least 3 or more risk factors for VTE. And these risk factors can include cancer, older age, prior VTE, central lines, immobility, sort of all of the things that go along with being in the hospital. And not only is the risk high during hospitalization, but as the duration of hospitalization kind of keeps getting shorter and shorter, the risk persists not only during the period of hospitalization, but for a substantial period after the hospitalization, as long as 45 to 60 days. Having said that, I think it's also important to recognize that the hospitalized patient population is actually quite diverse. And it can include patients who are admitted to the hospital for an acute medical illness, such as pneumonia or influenza. It can include critically ill patients, so patients who are admitted to the ICU for just more illness than can be handled on the floor, or septic shock, things like that, trauma certainly. It also includes cancer patients. That's about 20% of the hospitalized population. This can include, within this, you can also have active cancer patients. So cancer patients who are on active treatments such as chemotherapy or immune checkpoint inhibitor therapy, and now they're in the hospital either to receive elective treatment or because their disease has been complicated by an acute medical illness such as pneumonia. And so sometimes they can behave like an acutely ill medical patient does. Sometimes they're actually feeling fine. They're just there because the type of treatment that they're receiving can't be administered as an outpatient. And this population also includes patients who have a history of cancer but don't actually have cancer. So the cancer is in remission. And then finally, over the last couple of years, just to state the obvious, another subpopulation is COVID-19 patients, some of whom may be at risk, not just during the hospitalization period for VTE, but in the post-discharge period as well. And so when we speak of VTE in the hospitalization period and in the post-hospitalization period, it's good to keep in mind that we're actually talking about several different populations, and the risk amongst these populations can be quite variable. And even within individuals in this population can vary quite substantially as well. And that's kind of been the bane of understanding that this is a public health problem, but not being able to do as much about it as we would like to do. So the first step to sort of understand the problem is to understand who's at risk for VTE in the hospital. I think a shortcut is to say, oh, hospitalized patients are at risk, but as we just saw, the risk varies between these different subgroups. And the best way to sort of assess risk is through a risk assessment model that can identify in patients at high risk. And the recently published ASH clinical practice guidelines highlight two specific risk scores. Those are shown here, the Padua risk assessment model, and then the improve VTE risk assessment model. The Padua model was derived from essentially an expert consensus sort of approach, but has been validated and appears to hold up well in terms of discrimination of low risk versus high risk. And it includes factors such as a prior history of VTE, thrombophilia, active cancer, older age, here defined as age more than 70, reduced mobility. This is, a trauma conference, certainly recent trauma or any type of surgery can increase the risk, heart failure, respiratory failure, MI. But it also includes some minor risk factors such as a hormonal therapy, obesity defined as a BMI of more than 30, and then of course infection and rheumatologic disorders that increase the pro-inflammatory state. The improved score is based on a database. So it was derived from a database, has also been externally validated in multiple different data sets, may have sort of a slightly better performance than the Padua RAM score, and has a lower list of risk factors. So these include prior VTE, thrombophilia, active cancer, older age, but here defined as age more than 60, immobilization, lower limb paralysis, and critical care setting. These risk assessment models are important because we need to understand, so, I'm not gonna go through inpatient hospitalization prophylaxis, but in the post-discharge setting, what is the rationale for extending the prophylaxis beyond hospital discharge? The first is that if you look at it as a public health problem, actually most hospital-related VT events don't occur in the hospital. They occur outside of the hospital, but in a time period related to a recent hospitalization, typically the first month after discharge. And the risk, as we already saw, can be elevated for 45 to 60 days post-discharge. And this may be related to the fact that duration of inpatient prophylaxis is shortening because the duration of a hospital admission is shortening. So we admit sicker patients, but we discharge them fairly quickly. They're not 100% when they're discharged from the hospital, and they remain at risk for DVT or PE in the post-discharge setting. And in fact, most of these events will occur in that post-discharge setting. And so that's the rationale for saying, hey, we shouldn't stop prophylaxis just when people are in the hospital, because these people are sick even when they go home and they remain at risk for VTE. So what do the ASH guidelines recommend? And I'm sort of selecting the ASH guidelines here because these are the most recent, but also because they generally reflect consensus in the community and amongst other guidelines in terms of what to do in this post-discharge setting. And the bottom line is that currently there's not a real recommendation for post-discharge prophylaxis. So the ASH panel recommends inpatient only or inpatient plus extended duration outpatient prophylaxis. And this is actually a strong recommendation against post-discharge prophylaxis. And they explain the reason here. And I think it's important to go through these numbers because it gives you a sense of understanding why we are not, we are acknowledging that it's a big public health problem, yet we don't want to do something about it. And so the reasons are given here because, and they're focused on sort of the outcomes. What are the outcomes you're trying to prevent with post-discharge prophylaxis? And typically, the number one thing we want to prevent is mortality. We don't want people to go home from an acute medical illness that they're actually getting better from and then die at home from a pulmonary embolism. But the post-discharge prophylaxis trials do not show a benefit in terms of mortality. So if you add up sort of all the studies that have been done, there have been actually, this systematic review included 4 different randomized trials, and there were 0 fewer deaths per 1,000 patients who in terms of absolute risk reduction. Pulmonary embolism, yes, there is a reduction, but it's not huge. It's only 1 fewer pulmonary embolism per 1,000. Symptomatic DVT, 3 fewer DVTs per 1,000. And then major bleeding, which would be the argument against doing prophylaxis, is actually 4 more bleeds per 1,000. Not fatal bleeds, but 4 more major bleeds. And so because of this, in the systematic review, yes, there's a relative reduction in PE, but the absolute effects are quite small. And there's an increased risk in major bleeding. And therefore the panel decided that because of this lack of impact on absolute effects, post-discharge prophylaxis should not be recommended with any agent. They also specifically looked at outpatient prophylaxis, so extended post-discharge prophylaxis with DOACs as opposed to compared to just low molecular weight heparin when you're in the hospital. And essentially the same results. This included sort of 3 large randomized trials. In terms of mortality, 0 fewer deaths. In terms of PE, only 1 fewer PE. In terms of symptomatic proximal DVT, a little bit better, 2 fewer DVTs, but not an impressive enough absolute risk reduction. And then major bleeding, similar increase, 4 more bleeds per 1,000. And so again, based on this, strong recommendation with moderate certainty to not recommend post-discharge DOAC prophylaxis, specifically DOACs for this particular analysis. So to sort of summarize, why is extended prophylaxis not recommended? It may reduce PE and DVT, but the absolute impact on VT reduction is very small and is similar to the number of bleeding events caused. So those two balance each other out. And there is no impact on mortality. The panel agrees that it's possible, and I think this is really the crux of the problem, that the 3 included randomized trials did not select patients at a sufficiently high risk for VTE. This again goes back to the heterogeneity of the hospitalized patient population, how diverse it is in terms of the reasons that they're in the hospital, and in terms of their own risk for a DVT or PE based on their comorbidities and whatever's brought them into the hospital. The panel did comment on the Mariner trial, which used a modified improved VTE risk score, and I'll show that on the next slide, to select high-risk medical patients for extended rivaroxaban prophylaxis. But here also you can see sort of the results. If they look at the primary combined endpoint of symptomatic VTE or VTE-related death, hazard ratio is 0.76, but crossed 1, so the p-value was not statistically significant. And as you can see, there's sort of a crossing of the curves before there's a separation in favor of rivaroxaban. So there is some benefit, but it doesn't seem that even with this modified improved score that the population selected is that high risk. And then if you look at these 2 endpoints broken down, so symptomatic VTE or death is on top. Clearly no benefit there. The curves are overlapping. Symptomatic VTE, I think you can make an argument you are reducing that. Hazard ratio is 0.44, and the 95% confidence intervals don't cross 1, so this is significant. But notice, in terms of the scale, so when you put the scale from 0 to 100, those barely visible squiggly lines at the bottom is really the number of patients with events. So most patients will not have an event. And again, stressing, I think, that this is, even though it's selected, it's a well-designed risk score, has been validated, the positive predictive value, so the number of patients who will get a clot is not sufficiently high that you see sort of a clear benefit from, or a sufficient absolute benefit that you see from extended prophylaxis in the post-discharge setting. There's 2 exceptions to this, the 2 Cs, and that's cancer and COVID-19. And I want to talk briefly about those before finishing up. So with cancer VTE, we are seeing a different epidemiologic phenomenon. So this is really new data from Mulder and colleagues published in Blood just last year, looking at this very large Danish cohort extending between 1997 and 2017. And they looked at VT incidence over time in cancer patients and in the non-cancer population. And as you can see, the non-cancer population is down there at the bottom. The rates have not really changed that dramatically. Maybe a slight uptick in the 2000s, but again, not huge. Whereas the cancer cohort already high, continued to be high, and approaching sort of 3.5–4% per hospitalization. A second study published by Gary Lyman and colleagues a couple of years ago looks at rates of VT. This is, even though it was published in 18, the database only went to 2012. And here you can see VT in all patients on chemotherapy was about 8% per hospitalization. VT in all patients was about 6.5% per hospitalization, so substantially greater rates than the non-cancer population. And so I think this definitely reflects a burden on cancer patients that's greater than the burden on the non-cancer sick population that's admitted to the hospital. There's also high rates of arterial events. There is an association with mortality in the cancer population. And the VT in the cancer population is increased with more hospitalization as well as more prolonged hospitalization, and it delays cancer treatment. So quite consequential for people with cancer. But again, the road to prevention is complicated even in this setting. If you go by sort of the benchmark of 1 in 5 cancer patients will get a blood clot, it still means that 4 out of 5 cancer patients will never get a blood clot. And how do we separate out the people who will versus who won't? And here too, I think it's important to look at the setting. And in relationship to the discussion today about post-discharge, there's actually quite a lot of randomized clinical trials data looking at post-surgical discharge and showing that extended thromboprophylaxis in the post-surgical cancer setting. So these are not trauma patients, for instance, so they're not admitted, they might be cancer patients, they're admitted for a cancer operation. So these are not cancer patients admitted for trauma surgery, but they're cancer patients admitted for, typically actually in these trials, an abdominal or pelvic cancer surgery. Medically ill patients were part of the medical trials, but not exclusively. There's not an exclusive sort of cancer trial. And then in the outpatient setting, there have been trials separate from hospitalization, and I'll show you some of that data in a second. So in terms of primary prevention in ambulatory patients, this is probably one of the largest systematic reviews and meta-analyses of 6 randomized trials. Randomized patients to thromboprophylaxis with DOACs or low molecular weight heparin. As you can see, this is based on a validated risk score. A score of 2 or higher this analysis actually looked at score of 2 and then score of 2 higher than 2, so 3 or higher. About 2,800 randomized patients met the definition of score of 2, 1,700 met a score of 3 or higher. And if you scooch down here to the number needed to treat, you can see that for score of 2 or higher, it's about 25 patients to prevent 1 VTE. No real increase in major bleeding, although you saw more major bleeding with the DOAC trials than you did with the low molecular heparin trials. No worsening of mortality, maybe some benefit in terms of mortality improvement, and the number needed to treat lower as you go up on the score. So score of 3 or higher, number needed to treat drops to about 17. So not connected with immediate post-discharge, but outpatient prophylaxis for primary prevention. And the results of these trials have now been incorporated across ASCO, ASH, ISTH, all of the recent guidelines. After surgery, there have been a host of randomized clinical trials, as well as a host of observational studies, all looking at rates of VTE in this setting. And again, these are abdominal or pelvic cancer surgery, so not any surgery. It has to be cancer surgery. And all of these studies essentially suggest benefit from extended thromboprophylaxis. And if you're looking at numbers, it's about 1% in clinical VTE versus 2.1% with extended prophylaxis, without a significant increase in clinically relevant bleeding, so 4% versus 4.9%. And based on these data of all of these randomized trials, the current guidelines do recommend considering extended postoperative prophylaxis in this setting. COVID, another special population, also at much higher risk for VTE than the general hospitalized populations. There's not currently a consensus on the use of extended thromboprophylaxis beyond hospital stay. Post-discharge incidence is quite variable across different studies, ranging from 1 to 2.5%, less than 1 to 2.5%. The most recent data are from December, this Michelle trial that randomized COVID-19 patients with a high improved score at hospital discharge. So not every COVID patient, but patients with a specifically high improved score to either low-dose rivaroxaban or no anticoagulation for 35 days. I want to point out sort of what's been the criticism of this trial is that, so the study sort of scheme, the patient flow is shown on the left. I've blown it up on the right for readability. And what this shows is that of close to 1,000 patients were assessed for eligibility, almost 700 were excluded. So this really applies to a very small proportion of patients. About 180 declined to participate, which that might change if we have positive data. 175 had improved VT score less than 4, or the D-dimer was within the normal range. And then a bunch of other people didn't meet criteria for many other reasons. Some were already on anticoagulants, some had really long hospitalizations, some had a history of VTE or were in bad renal failure and so on. And so that's the concern, is that yes, the trial was positive, as I'll show in a second, but it only seems to apply to a small segment of the actual COVID hospitalized population. Significance was quite substantial. So it met superiority, 9.5% down to 3%. Number needed to treat to prevent 1 post-discharge event is 16. Relative risk reduction is 67%. Again, we prefer absolute risk reduction because that gives you a more meaningful understanding for patient benefit, and very pleasantly surprisingly, no difference in terms of major bleeding. And so that's the benefit to patients. But again, this isn't quite the consensus because has not been validated in other randomized trials. And as I mentioned, because of the screening issues and high number of patients needed to screen to actually get to the patients who would enroll on the trial. So to summarize, no question, post-discharge VT is a public health problem, but this population is really heterogeneous, very diverse. We have good risk assessment tools, but they're not good enough to have a high positive predictive value. And so they don't clearly identify a high-risk population that may benefit. Conceptually, yes, we need post-discharge prophylaxis, but in my opinion, and the opinion of many guidelines, we are not there yet. There are exceptions, and the exceptions of the two subpopulations, these are large exceptions, but there are the two subpopulations of cancer patients and COVID patients where rates are clearly higher than in the general non-cancer, non-COVID population. In the cancer population, there are no post-discharge studies, but there are outpatient primary prevention studies that have demonstrated benefit. And with COVID, there's at least Michelle, which is a clear, which has shown a clear benefit with low dose DOAC, but again, applicable to small subgroup and has not been confirmed. So I'll stop here. Just want to thank the people that support our research and actually do a lot of the research that I do here at the Cleveland Clinic, specifically NIH funding to our CLOT consortium through a U01 grant, the Sondra and Stephen Hardis family that supports my my personal research in sort of risk assessment and primary prevention, and then the clinic's Center of Excellence. So I'll stop here. Thank you. And if you have time for questions, I'm happy to take them.
Maybe one or two quick questions if there's someone. Sure.
Okay, so maybe just a couple quick questions. It seems like you've identified cancer and COVID as high risk for the need for post-discharge prophylaxis. Weeded down the trauma literature and your trauma data because it seems like that's a high risk, and there's a bit of Bayesian analysis that if they're higher, more severe injuries, they're going to need the post-discharge prophylaxis. And the second comment towards that is it really needs to be followed for about a year. It seems like your data is for weeks or months, but do you have any data that stretches it out for a year? Thank you.
Yeah, both great questions. Thank you. So in terms of, yes, the risk does persist, for several months, but most of those events occur in the first 45 to 60 days. It's also not clear to me when you sort of analyze that data, how much of that is driven by active conditions such as cancer. And so the persistent high rate that you see further out may not necessarily be from the hospitalization, but maybe from active comorbidities such as cancer or cancer treatment. So I think that's one concern with the very extended prophylaxis data. Regarding trauma, not again, I think that's another place where we need a better understanding of post-discharge risk and better being able to identify high-risk patients. ASH guidelines don't recommend post-trauma surgery that patients have extended prophylaxis. There's always exceptions for individual patients, but in general, there's not a lot of data to support that.